Hello and welcome. I'm Dr. Daniel Halbling, medical oncologist and member of the steering committee of the Swiss Tumor Board. The Swiss Tumor Board is an interactive workshop which happens 3 times a year. It just happened now today here in Bern, and today we'd like to discuss a very interesting prostate cancer case. So next to me sits Dr. Cantieni from the Inselspital in Bern. He is urologist, and on the other side Dr. Pesce, he's from the Josi in Bellinzona, he's radiation oncologist. Dr. Cantieni, could you please just give us a short introduction into the case and lead us through?
Hello and welcome. I'd like to present you a 65-year-old patient who was diagnosed with prostate cancer. He was referred to our outpatient clinics with lower urinary tract symptoms. He had clinical findings were a palpable tumor on the left side of the prostate, and the PSA was 116. And because of that, we performed prostate biopsies, which showed a bilateral adenocarcinoma with a Gleason pattern 3+4 with perineural infiltration. 80% of the biopsy material showed tumor. Then we performed staging with a CT scan and a bone scan, which showed no signs of metastasis.
What was found on the MRI?
The MRI of the prostate showed extracapsular infiltration on both sides.
Okay, so on this slide you will see all those findings, and now the question is, what would you do with such a patient? And what was done here in Bern with such a patient?
At this time, on one hand, we had his lower urinary tract symptoms in mind, as well as the extracapsular infiltration, as well as the elevated PSA of 116. And because of that, we decided to perform a radiotherapy under androgen deprivation therapy.
Okay, so there was an androgen deprivation therapy which started first, I think. You started with that for 3 months?
We
correct?
started 3 months prior to the radiotherapy. Then we performed IMRT, intensity modulated radiotherapy with 80 grays, and organ tracking.
Okay, very good. So now I'd like to come over to you, Dr. Pesce. This is an interesting case because we have a T3 tumor here, and we are reeling. This is one of those cases where one could discuss radiotherapy or surgery. And now I'd like to hear from you. When are you really in favor for radiotherapy?
As a general comment, radiotherapy and surgery have the same effect on survival for patients with prostate cancer. Then we have to select the proper treatment according to the risk factors. In this case, we can select, as an example, the value of the PSA, which was 160, and the T3 stage, which make surgery less indicated also because of the risk of a non-radical surgery. And we also know that sometimes we have to deal with side effects we can expect from the different treatment options as regards maybe sexual impotence and incontinence and rectal bleeding, which are the main side effects we can see with different options of treatment.
You think radiotherapy is better there?
In this case, we think that radiotherapy is better because of high risk of lymph node and distant metastasis because the patient is at very high risk according to prognostic scores already publicated like D'Amico and Partin tables.
Okay, so this is a high-risk case. For you it's clear radiotherapy is the option of choice. Then you also mentioned the side effects, which might be beneficial. I'd like to know now regarding the radiotherapy. It has evolved quite a lot. How are you applying these days the radiotherapy in such a case? How high do you go with the radiotherapy dose? And how are you doing it? Yes, do you give brachytherapy as well or not?
Actually, there are many radiotherapy modalities. What is clear from the literature is that if we go over 74 gray to the tumor, we enhance the probability of disease control, and that is translated in better biochemical disease-free survival. There are studies, randomized control studies showing that. And currently we have an improvement from technology with intensity modulated radiotherapy and many new tools that can allow us to better shape the dose, the distribution,
and to spare the organs.
And to spare the normal organs. Yeah,
especially the rectum, as you mentioned before.
Especially the rectum, yes.
Okay, very interesting. So you have to go as high as possible, is this correct?
As high as possible, as high as the studies show us till now. There are also new proposals with different dose schedules, but this is matter of current studies. As an example, with prostate radiosurgery in better prognostic situation, so low risk situations, but all the application of combination with external beam radiotherapy and brachytherapy boost. We have many new tools. We have to compare, to balance according to the situation. But it's clear that the higher the dose, the more is the possibility to control the disease.
This patient received 80 grays. Is this enough, or
is a standard of dose currently? The more of publicated studies report on 76 to 78 grays, but it's a matter of dose we can give to the prostate while sparing the rectum and the other normal organs.
Okay, thank you. Did it work, the radiotherapy, and how was there any anti-hormonal therapy as well given with that afterwards? Or?
He tolerated the radiotherapy well. The PSA decreased to a nadir of 0.2, and the ADT was kept for 2 years and then stopped.
ADT for 2 years and then stopped, and then what happened?
Then a year later, he was referred to our outpatient clinics again with a PSA increase to 18.1. And then we performed a restaging with the CT and the bone scan, and there we saw enlarged lymph nodes retroperitoneally without bone metastasis.
Okay, and then what was given? You see on the slide we show you as well in here, you made a decision to give...
The patient was asymptomatic at this time, so we decided to wait, and for a bone protection because of the ADT, we started with Samita. With
zoledronic acid, correct. There was some discussion in the tumor board whether this is necessary because there are no proven bone metastases and it is just given as a bone protection. But as Dr. Stenner pointed out, this is justified because the reason or because the likelihood of bone metastasis is really high in that situation, as we will see later on. So what happened? You gave him the zoledronic acid and then?
Within 6 months, the PSA increased to almost 50. And although the patient was still asymptomatic, we restarted the ADT.
You restarted the ADT. Did it help?
For a short period of about 2 to 3 months. Then it increased again to over 70.
Over 70. And then the next step, you...
Because there are a few percentage of patients with a flare-up under ADT, we performed a subcapsular orchiectomy.
Did you do the orchiectomy before you started the ADT again, or just during the ADT?
Just during. Okay,
but then there's also, as it was discussed at the board, another reason to do this, because sometimes some patients do have a failure under the ADT, the testosterone might rise, and then with the orchiectomy you really have that solved. And also another reason is that
The costs are lower, and in this case, we knew we had to keep on the ADT.
forever.
Forever.
Yes.
Yes.
Okay. So then, what happened?
Unfortunately, the PSA progressed to over 110. We performed the restaging again.
You will
with
see
the
on the
CT
slide.
scan and the bone scan, and there we saw a solitary bone metastasis of the lumbar vertebra, 4 progredient lymphadenopathy, and solitary nodule suspicious for pulmonary metastasis.
Okay, so we had lymph nodes now, we had pulmonary metastasis, and we have the bone metastasis as well. So kind of a progressive disease, but the patient was asymptomatic. And what did you do?
We discussed several chemotherapies, radiotherapy, and abiraterone as well, but we decided for a chemotherapy with Taxotere.
That's the standard in a way, one has to say, because only Taxotere is approved in this situation. Abiraterone would not be approved because it was given second line in the big trial, we know. So you gave the Taxotere. This was not going so well. You only could do 6 cycles, I think.
Yes, the patient had neurological symptoms. He had paresthesia on hands and feet.
That's very common on the Taxotere, or it might arise on the Taxotere. It's not
We had
uncommon.
to stop, but the PSA reacted well on this therapy. It decreased to 50.
Okay, so it was effective. It was effective, but it could not be given as it was given in the trial. It was given over 10 cycles as a median in the TANOC trial. Here it was given for 6 cycles because of toxicity. But you had an effect. You felt the PSA, and then?
And then, unfortunately, again, it increased within a short period of 6 months to 320.
And what happened as well? You made a restaging, I think.
We performed another restaging, of course, and there we saw a progredient lymphadenopathy and multiple sclerotic bone lesions at this time.
And then there was the discussion what to do next. The patient is still asymptomatic, but he had a rising PSA and the lymph nodes in the retroperitoneum. And Dr. Stendorf from the University Hospital in Zurich pointed out this is a good reason to start with a new therapy, and you decided to go for
At this point, we started with abiraterone.
abiraterone. And this was presumably the right decision because the patient did not have any symptoms from leg swellings or scrotal swellings, because this can happen when you have enlarged lymph nodes in the retroperitoneum. And what happened with the PSA under this treatment?
It decreased to 50, then it increased a little bit. Now it's up at about stable at about 80.
Okay, so the patient is at the moment still
Asymptomatic, and he tolerates the therapy well with a mild hypokalemia and mild hypertension.
some symptoms which might occur under abiraterone. So thank you very much. This is an illustrative case, I think, where we see what best treatment can be given as initial treatment, and later on you see all the lines which we have now in the meantime as the patient progresses. So thank you very much for you both. Further cases will be presented after the next meeting, which will be on the 13th of September 2012 here in Bern again. So join us if you like. You would be most welcome, and see you again, perhaps next time. Bye-bye.